Welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and leader at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer your questions from chapter's members about the COVID-19 pandemic. Today is July 28, 2020. The United States has reached almost 4.5 million total cases since the start of the COVID outbreak, and we have over 150,000 deaths. The good news is that our comparative 7-day average in terms of new cases has gone down by 14%. The bad news, and not unexpectedly, is that the mortality rate has gone up 18%. This is as expected, going 2 to 3 weeks after the last surge of cases in our 4 states. Also, since our last podcast, Arizona briefly achieved international reputation as being number 1 in the world for its attack rate of new cases. However, fortunately, there are early indications today that our curve is flattening once again in response to increased use of masking and our attempts at social distancing. So we have, again, a good range of questions. We'll start off with the first one and most important one. Can patients get infected with the coronavirus more than one time? This is the great question, and the answer is a cautious, we don't think so. Here's what we do know. It is apparent that patients, even with mild or asymptomatic COVID-19 cases, do yet still mount an antibody response. Right now, it appears that the detectable antibody response, i.e. what you would find on a laboratory test, lasts for at least 6 to 7 weeks, but then may diminish to being undetectable. However, the presence of neutralizing antibodies, i.e. the antibodies which actually do the work of the humoral or adaptive immune system, those persist for longer. So it appears unlikely that an individual, even if they had mild or asymptomatic COVID-19, could get infected a second time. Also, it appears that the virus, although it is undergoing mild mutations to specific variants out there as we now speak, the mutations only exist in modifications of the spike protein or the attachment protein, not in terms of new virulence, new pathogenicity. So even if the virus continues to mutate a bit further, it's highly unlikely that it could mutate to cause a second attack or a second case, unlike what we see every year with epidemic influenza. So, right now, the answer cautious no, we cannot get infected with the coronavirus more than one time. As always, the caveat, time will tell, as will, of course, additional research. Turning now to some questions about testing. What is better for testing, the nasopharyngeal swab or the oral swab, or the actually very recently approved saliva test? Ultimately, and in a perfect and ideal laboratory setting, the nasopharyngeal swab is the best one. Why? Because the virus itself is attaching most prominently to nasopharyngeal epithelial cells, and that's where it starts its infection and its initial replication. Thus, going to the scene of the crime, i.e. the posterior nasopharynx, is the best way to get early virus detection in a most sensitive way. Caveat, it is, as everyone who's performed these tests knows, very difficult to get an adequate nasopharyngeal swab. The swab has to be pushed all the way back. Some joke we were in the process of obtaining a brain biopsy or sampling cerebrospinal fluid through the nasopharynx, and the swab has to be left there for quite some time. The key is to get nasopharyngeal epithelial cells on the swab itself. So the oral swab and certainly the saliva test are far easier to obtain and therefore may be more likely to be obtained successfully in terms of technique. So if one's technique is valid, those of us who trained sufficiently early to where we remember getting RSV specimens by cutting the top off a IV stylet and sucking or sampling secretions from the oral saline, we got quite good at that because we did hundreds every night. However, if one has not done many nasopharyngeal swabs, then perhaps the oral swab or saliva specimens are the better, more sensitive ways to go. What about the infant born to a COVID-positive mom who themselves, the infant, also tests positive? Should we be retesting the infant prior to seeing them for that first well-child examination? And the answer is no. Because a retest will not provide any additional meaningful information. The infant has been exposed and with a positive test, presumably has been infected in that perinatal or immediate postnatal period. However, the infant is highly unlikely to be highly contagious and is unlikely, thankfully, to have disease. So, other than requesting the caretaker who brings the child to that healthcare visit to mask, and as one's self, as the healthcare provider, masking appropriately, using normal universal precautions, i.e., hand hygiene, etc., and so forth, that there are no additional interventions that one would perform for that child. Other than just being aware that they may theoretically be slightly contagious. Having either another positive repeat test or even a negative repeat test will not change our approach in the office. So my answer to retesting for a COVID positive infant is no. What about sports clearance? So our children, our student athletes who are coming to the office to participate in sports, school sports, which is, of course, a very complicated issue. And I'll touch on the return to school and school sports in just a little bit. But just in general, what does it take to clear a patient who is previously positive for COVID-19 to clear them for sports? Do we need any additional, example, cardiac follow-up? Do we need to do anything additional? And the answer is no. Once again, applying what we know from the virus itself and its pathogenesis, and also the updated recommendations from the CDC, basically any patient, and here I'm including our student athletes, can be removed from isolation 10 days after their time of diagnosis, assuming that they have been at least 72 hours without any symptoms whatsoever. So afebrile resolution of active respiratory symptoms. This does not include those patients who have persistence of their shortness of breath, or those patients who are known asthmatics who have persistence in wheezing or cough equivalent asthma. It is known that COVID-19 survivors have prolonged mild respiratory symptoms for weeks to, in some cases, months after the onset of their infection. They are not known to be contagious. So, a student then who's 10 days out from diagnosis from formerly being positive for COVID-19 can be cleared to participate in sports from the environmental risk perspective. What about their exercise tolerance? That is, of course, going to have to be individualized. So the known asthmatic, well, if they're still having wheezing, they may not be the best candidate to be given, full ride to return to an aerobic sport. So again, as we would with any patient who has underlying health concerns, just evaluating it on a case-by-case basis, I don't believe we need to do anything additional or special just because they may have been infected with COVID-19. This extends also to the question about cardiac follow-up. In general, children, certainly under age 10, and even young adults under age 18, our age group, are not at high risk for the cardiac complications that have been reported in older adult patients with underlying cardiac disease. So, as a sort of de novo viral infection, SARS coronavirus 2 is not known to create or cause new cardiac disease in somebody who previously was healthy. Therefore, there's no additional indication to do additional cardiac screening other than what we're already doing at baseline, whether that's an EKG or the family history of cardiac disease, even considering like a pre-sports echocardiogram. So that's where we are in terms of the medical clearance for a student athlete. What about treatment? And of course, we continue to see lots of additional evidence of theoretic agents. Certainly, the story of the antiparasitic medications, including hydroxychloroquine, with or without azithromycin, and even ivermectin, as used in Central and South America. There are still some areas of the world that are using these medications in the belief that they are positively affecting outcome. The data, as it continues to be submitted, does not show any difference in outcomes in patients treated with hydroxychloroquine or ivermectin or azithromycin compared to control patients who did not have those medications. Again, I could not support use of anti-infectives such as those for the patients who are positive. However, there does continue to be continued good evidence for remdesivir, an antiviral which has apparent specific antiviral activity. What that really is helping is to prevent the virus from uncloaking, if you will, or from further replicating itself after initial infection occurs. So a 30% reduction in hospital stay, in severity of outcome, has been demonstrated in some studies with remdesivir. The biggest interventions, of course, continue to be the steroids, because a majority of the severe signs and symptoms associated with COVID-19 are all immune-based or inflammatory-based. So, dexamethasone 6 milligrams daily for the adult patients, and even for young adult patients, continues to be highly recommended for hospitalized patients with any degree of respiratory failure or respiratory distress associated with infection. Very recently, a study of patients with known asthma who received a prednisone burst, the typical 5-day burst, also showed a similar reduction in severity and reduction in hospital stay. So at least the systemic steroids that have been administered for COVID-positive patients have continued demonstration of effect. Some of the adjunctive therapies, and one of our questions asked about internists who are starting adults on vitamin D, vitamin C, zinc, or even giving azithromycin. These, after the fact, really don't have evidence-based impact on the outcome of the virus. Certainly somebody who is fully replete with vitamin C or vitamin D or even zinc may have the ability to avoid viral infection. And this actually stems from studies done with HIV infection in parts of Africa. But to start a vitamin supplementation or to start zinc or any of the over-the-counter products, as we know about, to start those after infection with SARS-CoV-2 so far has not been demonstrated to have any meaningful impact on length of symptoms, length of hospitalization if the patient is hospitalized. So I could not support application, as some internal medicine providers are doing, of doing those things for kids. Certainly there are no recommendations formally to do that kind of an intervention. Similarly, one of the questions asked about use of budesonide in the first 3 days of symptoms. Again, an inhaled steroid theoretically has the potential to have positive impact on a patient who's experiencing respiratory symptoms from their COVID-19. So in that case, if the patient certainly is having reactive airway disease or what we might suspect to be early respiratory distress, yes, that's a patient in whom I might consider use of either systemic or inhaled steroids in the hope and anticipation of reducing that inflammatory burst which is causing the symptoms. Related question, what about those of our patients with a history of asthma who are typically on controller medications, including inhaled steroids or other stabilizers during the winter months? Should they start those winter regimens during the summer, like right now? Even if they have no symptoms? And the answer is no. That there does not appear any higher risk of developing symptomatic or severe disease, even with that as a background history. And so, use of the winter asthma regimen right now in the absence of symptoms cannot be supported. That said, I personally, as a treating physician, would have a very low threshold or a very quick trigger finger to start a steroid intervention in a patient that I confirm to be COVID-19 positive who has some respiratory symptoms, including hypoxia, difficulty breathing, shortness of breath, chest tightness, the whole 9 yards. Moving now to some outcomes. And this is an interesting question, asking about, do we know what percentage of people who have died with COVID-19 had a prior designation to allow natural death or a do not resuscitate order? The thinking being that these are patients who may not have received the full benefit of advanced medical care in this country and thus might be skewing the mortality rates. Great question. I also don't have access to any numbers. I'm not really aware that we were able to recruit those numbers. Personally, I think those numbers are quite low, just in terms of the number of patients who actually have active AND or DNR orders on their charts that are recognized and observed by transporting EMS providers or in hospital. I think a bigger impact, though, on the mortality rate has to do with a huge segment of the population that are underserved and under-resourced and don't have access to healthcare in the first place. And here I'm thinking of our populations in inner-city neighborhoods, our patients of color, blacks, those who are Latinx, our native populations. Many of these groups are having very poor or limited access to emergency services and advanced health care and are dying at home. There's clear evidence of this occurring in multiple situations in New York City, and certainly even in the state of New York in the 5 boroughs, where patients were basically unable to be transported. It was too high a risk for the EMTs, and they were basically left at home to die. So the mortality rates which we see absolutely are skewed much more high from those populations because they were never given the opportunity to access advanced healthcare delivery. Those clinical case series that have been able to look at patients with full access to healthcare delivery, who got the full ride, who had the benefit of first world medicine, such as we hope to provide in parts of the United States, not all. Those individuals have a mortality rate which on average is no higher than 4%. And that's all comers. Once again, different age groups have higher risks. Patients with the comorbidities, hypertension, diabetes, cardiovascular disease, obesity, immunodeficiency, all are high-risk comorbidities with a higher mortality rate assigned to those. So it is very difficult to give a universal mortality rate without also recognizing that there are absolutely parts of the population that will skew that in one way or the other. In pediatrics, thankfully, the mortality rates and even the morbidity rates, so those children with symptomatic disease are far lower than in adult and young adult patients who are certainly older than age 20 and maybe even older than age 10 if we want to drop that age cutoff a little bit. So last little bit, and I'm going to touch on this just briefly because we anticipate an upcoming webinar with a panel from the Arizona chapter of the American Academy of Pediatrics. This has to do with the hottest topic right now for all of us, and that is school reentry. Multiple questions, multiple issues. Certainly, I think many of us have many opinions on this, and we're asking very legitimate questions. And I'll summarize those right now by quoting, if I may, one of our questioners. Is it folly to risk the health of our kids and our families based on the lack of data, lack is capitalized, lack of data we have now on transmission in schools? Yeah, absolutely. It is incredible folly to be making policy based on trends which are poorly described, based on political implications, based on a need to appear that we're safe to return to life as we know it. Certainly there's ample evidence in parts of the world and parts of this country where reentry has occurred too soon with a temporally associated increase in cases and death rates. So yeah, I completely agree. What is the data such as we know it? There is actually a recently released study from South Korea, and South Korea, again, did a really good job of managing their COVID-19 outbreak. So researchers in South Korea followed nearly 60,000 contacts of 5,700 known COVID-positive patients. They followed them for 10 days, and they looked at rate of transmission within the household. On average, there's a 12% attack rate of household contacts, meaning 12% of household contacts of a known COVID-19 index patient became infected, compared to only 2% that were non-household related. So For those of us in the healthcare field, again, good news, because most of our healthcare positives are being acquired at home, not in the hospitals, not in the clinics, not in the healthcare setting. But in terms then of an age difference of those household contacts, when the index patient, so our COVID-19 patient, was aged 10 years old to 19 years old, so typical sort of middle school, high school age student, then 19% of those household contacts were infected. In contrast, adult patients who are the index patients, ages 30 to 49 and higher, 12%. So that actually achieves statistical significance. So kids aged 10 to 19 had a higher rate of transmitting their infection to household contacts. In direct contrast, when the index patient was age 0 to 9, so we'll sort of include up through elementary age, only 5% of household contacts were infected. So a clear difference based on the age of the child. This flies in the face of a blanket recommendation to send every child back to school without recognizing that there's a differential risk of transmitting at the school or at home based on how old the child is. So, a return to school for elementary age children seems to be less risky, I'm not saying zero risk, but less risky than the average community versus those who are middle school and high school aged. Now, this was assuming that no masking occurred at home and that other barrier methods were not used. So if one were able to provide a highly effective way of masking and hand hygiene and social distancing within the school setting, and we're talking resources upon resources and supervision and support, and the list goes on, then maybe theoretically it might be possible to send our high school and middle school age children back to school physically safely. However, there are a whole bunch of ifs, ands, or buts there that need to be satisfied before we can even consider that. That takes time. And although this is now off the table, but the formally established August 17th go live date to go back to school was going to be way too soon to allow this to occur. So with a whole bunch of support, with a whole bunch of planning, with certainly a far greater reduction in community cases in Arizona, then we might be able to consider a full return to school. In the meantime, I think there needs to be an age-based approach to that, so that those in elementary school, especially, and those are children who are less likely to be able to wear or continue to wear masks in the school setting, those are kids who are probably safer in terms of lower rates of transmission and certainly far lower rates of symptomatic disease on their own in terms of personal patient safety. So I'm not about to pretend that I have a simple answer for all of this. Clearly, it needs to be a very active, open, transparent conversation and discussion between our policy leaders, our thought leaders, and applying what evidence we have. I've shared with you really the best evidence we have to date based on a larger study, and hopefully that can inform our conversations going forward. I do invite you to join us when we do have this webinar and panel discussion to try and help inform the conversation going forward. So that's it for the questions. Thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to COVID, COVID, at azaap.org. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member of the chapter, please visit azaap.org. Once again, thanks for listening. Stay safe, stay sane, stay positive.